Good morning, good afternoon, whatever. Welcome to our Thursday research conference in the Department of Medical Informatics and Clinical Epidemiology. As sometimes happens, I see faces I don't recognize, which is actually a good thing, meaning that the information is getting out. As you probably know, we have a speaker that's a little bit different today than some of the usual speakers, moving away from some of the detailed technology issues, but which, of course, everyone recognizes is such a critical issue for what we do, which is privacy. So our speaker today is Andrea Meyer, who's the legislative director of the ACLU of Oregon. She's been in that position since 1999. During the legislative session, she monitors all kinds of issues, not just health IT, but other issues and their civil rights implications, everything from privacy, reproductive rights, free speech, GLBT issues, religious freedom, and criminal justice. She also handles ACLU efforts on initiative, petition, and ballot measure campaign work. In 2001, Andrea was appointed as privacy representative on the Advisory Council on Genetic Privacy and Research, where she continues to serve. And prior to joining the ACLU, she clerked for U.S. Magistrate Janice Stewart and also practiced at a small civil litigation firm in Portland. She's a graduate of the Lewis and Clark Law School and did her undergraduate work at Oberlin College. And so she's going to give us her thoughts on this issue, and she has promised that she'll leave plenty of time for discussion, and I'm sure there will be some. And so I will let her get started.
Thank you. And I understand this has been advertised as a PowerPoint-free talk, and it will be. So that's it. But I want to, and I will watch the clock and try to leave time for the opportunity for discussion and dialogue. I want to thank you for the opportunity to present ACLU's perspective regarding the creation of electronic healthcare records. As I think you all know, the issue raises many questions as well as challenges, and I will attempt only to superficially cover some of the many substantive issues. Overall, the question is, how do we as a society use technology to improve medical practice and care, while at the same time understanding and addressing the new and different risks that are created as a result of the use of technology? And let me just briefly explain for those of you who may not know what the American Civil Liberties Union does. We started over 90 years ago when the U.S. Attorney at the time, General Mitchell Palmer, began rounding up and deporting so-called radicals. And thousands of people were arrested and detained without regard to constitutional protections. So in the face of those abuses, a small group of people decided to take a stand, and thus was born the ACLU. The Oregon affiliate was started in 1955. We work daily in the courts, the legislature, and in communities to defend and advance individual rights and civil liberties. So many of you know about the Fourth Amendment prohibition against unreasonable search and seizure. And from that, as well as through other sources, arises our concerns about privacy. While the Constitution refers to limitations against government actions, the ACLU looks not only at what the Constitution and laws allow, but what should be the best policies and practices in our society, regardless of whether they are done by the government or the private sector. The effect of technology on our expectation of privacy is an area that I could spend days on, but I will simply focus on the issues around privacy, technology, and healthcare. And if I have time, I will touch on the recent state law implementing a prescription database monitoring program, affectionately referred by those who are starting to run it as PDUMP, but we will leave that to the end. So what is health IT? Now, as you all know, generally health information technology refers to the practice of medicine through the electronic collecting and sharing of information. And most discussions center around the creation and use of personal health records, electronic health records, and databases of these records. And I will focus on electronic healthcare records and not the issues around personal health records. Proponents of health IT believe that everyone will benefit from such a system. For example, patients could have better access to their records of their treatment and tests. Providers could easily learn a patient's relevant medical history. And researchers could access data about what treatments work best. But along with that promise of more efficient and effective medicine, health IT also raises serious concerns about personal privacy. Health records often contain very sensitive personal information like treatment for mental health issues, depression or alcoholism, fertility treatments or abortions, sexually transmitted diseases and other communicable diseases, and genetic disease screening. A violation of medical privacy might result in the disclosure of this information to family, neighbors, community, employers, marketers, or identity and data thieves. Given the high stakes in protecting the sensitive information, it is essential that medical privacy form a cornerstone of any health IT initiative. It's fair to say that both doctors and patients worry that their personally identifiable medical data will not be adequately protected. Past experience and studies show that if the confidentiality of electronic medical records is not guaranteed, a number of unfortunate consequences might occur, such as an employer, after inappropriately reviewing electronic medical records, deciding not to hire a candidate for a job because either the candidate or his or her family is relatively expensive to insure. And before there were some amended privacy rules, there were 35% of Fortune 500 companies admitted to reviewing job candidate health records before making hiring decisions. Data brokers buying up pharmaceutical and medical records of millions of patients and selling them to anyone willing. And there was a 2008 case out of the First Circuit upholding New Hampshire's law prohibiting the sale of certain pharmacy records to patients. Pharmaceutical companies sending invasive marketing solicitations to induce patients to switch to companies' prescription medicines instead of those prescribed by the doctor. I smile. I remember getting something like that. Didn't make me happy that they even knew what prescriptions I was using. Persons in small communities or someone in a prominent position may face consequences both socially and professionally. Employees and snooping on neighbors, friends, and former love interest medical records, and uninsured individuals committing medical identity theft by impersonating insured patients whose records they have snooped on in order to obtain treatment. Health information technology and health information exchange can help improve healthcare quality and efficiency while also empowering consumers to play a greater role in their health care. However, health IT initiatives pose heightened risk to privacy. Recent breaches of health information underscore that real risk. At the same time, there is widespread confusion and misinterpretation about the scopes of current health privacy laws. And some are pushing for quick fixes to try to address the public's privacy concerns. But fully resolving these issues requires a comprehensive, thoughtful, and flexible approach. I want to quote a bit from the Center for Democracy and Technology in a paper they published in May 2008. And that paper was called Comprehensive Privacy and Security Critical for Health Information Technology. Rather than treating privacy and security as being obstacles, they look at those concerns as a means of ensuring success. Quote, while some persist in positioning privacy as an obstacle to achieving the advances that greater use of health IT can bring, it is clear that the opposite is true. Enhanced privacy and security built into health IT systems will bolster consumer trust and confidence and spur more rapid adoption of health IT and realization of its potential benefits. They quote survey data that shows Americans are aware of both the benefits and risks of health IT. Quote, a large majority of the public wants electronic access to their personal health information, both for themselves and for their healthcare providers, because they believe such access is likely to increase their quality of care. At the same time, people have significant concerns about the privacy of their medical records. They quote a national survey that was conducted in 2005 and 2006, and while it's only a few years old, I think it's hard to imagine that the concerns expressed then have significantly changed in the past few years. In 2005, 67% of respondents were somewhat or very concerned about the privacy of their personal medical records. In a 2006 survey, when Americans were asked about the benefits of and concerns about online health information, 80% said they are very concerned about identity theft or fraud. 77% reported being very concerned about their medical information being used for marketing purposes. 56% were concerned about employers having access to their health information. And 53% were concerned about insurers gaining access to this information. They conclude, quote, appropriate privacy protections must be incorporated from the outset in the design of new health IT systems and policies. It is often difficult or impossible. Oh, did I not say, please? It is often difficult or impossible to establish privacy protections retroactively and restoring public trust that has been significantly undermined is much more difficult than building it at the start. How can health IT be structured to protect personal privacy? Given these serious concerns about personal privacy, it is essential that policymakers, experts, and designers, many of you involved in health IT, keep privacy at the center of discussion and implementation. Here are some important questions related to patient privacy within any health IT systems. And I raise a lot of issues. Doesn't mean I have all the answers, or any of the answers, but at least I will raise the issues. How do we explain to patients that benefits and risks in a way that can be best understood for individual choice? Can patients opt out of the system and still receive medical care? What method do we use for whether patients participate? Opt-in, opt-out, exceptions, granularity? Is there a way to minimize data sharing or allow sharing of only part of the data? The patient may not want a podiatrist or someone else treating an ingrown toenail to see their psychiatric records. An adolescent may not want a parent to see that they've been treated for a sexually transmitted infection, for example. Who decides what specially protected health information is? State law? The medical community? Patients? Isn't it different for everyone? Can patients access their own data at no cost? Is there a way for patients to add information or raise concerns about the facts in a medical report? I'm currently reading the Pain Chronicles by Melanie Thernstrom, and I'd highly recommend it. But what was interesting is she said when she received copies of her records, the first doctor she saw had the very basic facts about what triggered the onset of her complaint completely wrong. If records can't be corrected, how can they be clarified from a patient's perspective? How will patients control who has access to their information? How is the data secured? How will patients know when their data has been disclosed? Under what circumstances do patients receive notice of data breach? How is medical identity theft handled? Are there remedies available to a patient if their data has been breached? How anonymous is data that has been aggregated or de-identified? What type of auditing system is in place to ensure proper use? What means are taken for patients to meaningfully understand their rights? So I'm going to discuss a few of these in more detail. Patient choice and the issue of opting in, opting out, and segregating records based on the sensitivity of the information. First, while this issue is very important, I think the Center for Democracy and Technology makes an interesting point. Quote, if health privacy rules fail to address the range of privacy and security issues through concrete policies, and I might add meaningful remedies, which I will discuss below, and instead rely only or significantly on giving individuals the right to consent to multiple use and disclosures of their personal health information, the result is likely to be a system that is less protective of privacy and confidentiality. Among other reasons, a consent-based system places most of the burden of privacy protections on patients at a time when they may be least able to make complicated decisions about the use of their health data. Most don't read the details of a consent form, and those who often do not understand the terms. Many wrongly assume that the existence of a privacy policy means that their personal information will not be shared, even when the policy and the accompanying consent form say just the opposite. If reliance on consent by an individual for any particular use of his or her information is treated as policymakers as the key to privacy protections, the healthcare industry will have fewer incentives to design systems with stronger privacy and security protections, unquote. Nevertheless, patient control and meaningful decision-making is still a critical piece, and it raises important policy questions. Should patients be allowed to consent at the front end to participate in the electronic exchange of their records? While this may be considered burdensome, if patients understand and choose to have their information shared electronically, one can make the argument that it helps establish an important level of trust. Because while there are benefits, there are also risks, including possible breach or misuse of private medical information. And then when there is a breach of some kind, and I think it's often safe to say there will be, it's just a question of when, not if, does the fact that a patient was informed about the risks and had some understanding, not only the benefits, but those risks and the safeguards taken, lessen the potential for long-term damage of a breach, such as patients refusing to participate in electronic health care exchange or limiting the medical information that they share with their doctor? Let's look at it from the opposite. if a patient isn't given the option to consent and is instead automatically enrolled or barely informed about how to opt out, and there is a breach, what does that do for patient trust? Patients, a community, or everyone in the state who did not understand that there was electronic sharing of their medical information, but now have their information released in some unacceptable manner, may never trust the system again. And that may exacerbate the following problem already noted by the Center for Democracy and Technology, which they refer to as privacy protective behaviors. Something many of you may have already heard of. It was new to me. But according to the 2005 National Consumer Survey I mentioned above, 1 in 6 adults, 17%, representing 38 million persons, say they withhold information from their health providers due to worries about how the medical data might be disclosed. Quote, persons who report that they are in fair or poor health, and racial and ethnic minorities report even higher levels of concern about the privacy of their personal medical records and are more likely than average to practice privacy protection behaviors. They note that we already have a problem with patients who attempt to shield themselves from stigma or discrimination by paying out of pocket, asking doctors to fudge a diagnosis, switching doctors frequently to avoid having all their records in one location, lying, or even avoiding seeking health care altogether. It may take work, but we suggest it's important to work to explain to patients the benefits and risks, if not only to ensure that patients are sharing the necessary information you need to make medical health care decisions. And that raises another issue. What level of control does a patient have over the who's, what's, where's, and when's of their medical information? In the debate around this, the term often used is granularity, which has different applications, but in general allows the segregation of health information, sometimes based on specially protected health information, but not always. It refers to segregating data to, one, allow patients to exert some control over the type and level of information that can be shared. Second, to restrict information access electronically to a set of individuals or entities. 3, to establish preferences for time frame and or duration for what information can be electronically exchanged. And 4, to specify the various purposes for which information access electronically can be used. Again, it comes as no surprise, this is a complicated area. But a person's rationale for desiring this level of control may stem from concern or fear of how the information available through electronic exchange could be perceived or used, a personal preference for privacy, or their individual values. Whatever the reason, it's important to acknowledge and respect those concerns up front, so appropriate steps can be taken to advance the goal of health information exchange while still respecting fundamental autonomy and values. The challenge, however, is that in the context of electronic healthcare record exchange, there is no easy solution to the challenges raised by these issues. To add another wrinkle, while Oregon law defines what specially protected health information is, which requires specific consent for sharing this information, those laws only cover mental health treatment, some aspects of HIV/AIDS, genetic information, and a minor's reproductive care. That's a start, but for many of us, what we consider specially protected health information may not be on that list. What about reproductive health care, including abortion and other reproductive care for adults? That's not specially protected health information under Oregon law. But you can imagine patients not wanting it released through various healthcare systems by electronic transmission of their records. And what about antidepressant drugs used for non-mental health purposes? Some of those drugs are used for other conditions that may not fall under specially protected health information. Patients may not want that information released to every healthcare provider if they worry about whether a breach would lead to the perception that they have mental health conditions. As much as we want to move away from the stigmatization in our society related to mental health issues, we aren't there yet. As mentioned above, sensitive information may have significant personal, employment, or political consequences, including the loss of employment, public shaming, discrimination, and disruption of personal and familial relationships. There are important policy reasons to allow for granular approach, especially information that has been used to stigmatize patients in the past, such as psychiatric or other mental health and counseling, the use of birth control and testing for sexually transmitted diseases, and other conditions or genetic predispositions that have no bearing on a doctor's evaluation, diagnosis, or treatment for a wholly unrelated condition. Another area to consider: can patients opt out of the system and still receive medical care? This is often referred to as a non-discrimination policy because it allows someone to opt out of the system without creating a barrier to care. choosing not to participate can only be a choice if a patient can still obtain care regardless of their decision whether or not to participate in electronic health exchange. And what about data security and meaningful remedies? One thing we really do know for sure, as I mentioned, is that breaches happen. And the healthcare community is not immune. Every time I've reviewed the Privacy Rights Clearinghouse website, which I recommend to all of you, they keep track of all the breaches of any kind across the country. I find that there's one breach of any kind on average day, and I see a significantly high number in the healthcare community. There are, of course, risks to inappropriate access to paper healthcare records. And with the use of technology comes the ability to create stronger use, authentication, and audit trails to limit and track access to electronic health information. Encryption can help to ensure that sensitive data is not accessed when a system has been breached. I've been told by those who work in the IT medical area that most breaches are not from the outside hacker, but by those who are authorized users of the system but are engaged in improper access and use. Also, the absence of strong privacy and security safeguards magnifies the unique risks to electronic healthcare records. Unlike paper records, tens of thousands of electronic health records can be accessed or disclosed through a single breach. And the result of the documented breaches across the state and here in Oregon not only create a real risk to individuals, but it also has a cumulative effect to deepen consumer distrust in the ability of healthcare providers to provide adequate privacy and security protections. Patients need to know when and how their data has been breached. We're getting better about requiring notices related to breach, but notice of any breach of any kind, be it internal or external, should be mandatory and timely. And meaningful security also means meaningful remedies and enforcement mechanisms. And yes, I mean the L word, liability. But we believe that the failure to take the appropriate steps to secure data should subject the entities to exposure to damages. Here I'm talking about the negligent and irresponsible entity that has no incentive to ensure strong data security system because there's no real punishment for the failure. They need an incentive so that we avoid creating situations where data is being inappropriately accessed. And one way is to have exposure to appropriate level of liability for the individual who is harmed, not just the state or the federal government, if they fail to take reasonable steps. Finally, how do we handle the issues related to medical identity theft? Medical identity theft refers to the fraudulent use of someone else's personal information to obtain medical services or to make false claims for medical services. In addition to the complications that arise from straightening out other forms of identity theft, some of you may have had to deal with this, such as clearing up bills for expensive services actually received by someone else. Medical identity theft can lead to inaccurate information in the victim's electronic health record with possible dire results. For example, an identity thief could obtain treatment under the victim's name, leading to false information about blood type, drug allergies, treatment or existing conditions, which could then later lead to unnecessary or dangerous treatment for the victim. As more personal health information is centralized under health IT, medical identity theft becomes more likely and the consequences more worrisome. The victims of identity theft must have a mechanism to remove information from their medical records that may adversely affect their treatment. And if medical information is transmitted to various entities, there has to be a way to correct this information beyond contacting the originator of that information. This reinforces the need for any health IT system to include robust data security measures as well as provisions for patients to discover and correct errors. Now, no doubt, this is a complicated area. And one thing I've observed in the last few years as Oregon begins to grapple with this issue is the continued disconnect between the issues of electronic health care records and privacy. It's as if privacy is a separate, often final issue on a long checklist. Instead, privacy needs to be fully integrated into every aspect, discussion, and decision point related to the development of electronic healthcare records. I've testified before various bodies in the state involved in this. Indeed, prior to the creation of the most recent state commission, HITALK, Health Information Technology Oversight Council, I was informally asked to serve on the subcommittee of the previous group related to privacy. I was the only non-member who was asked to participate in this way. And while I appreciated the opportunity, it was also troubling that there was a significant lack of privacy perspective from those most involved. Obviously, those who are involved at this stage are those most affected by these systems, and in other words, those in the healthcare community. And I appreciate the efforts made by those attempting to inform the process to reach out to consumers as well as to various communities who historically are less involved in state decision-making processes. However, I continue to be troubled by the conversation and how, absent the ACLU voice, there is little recognition, let alone meaningful discussion by well-intentioned people about privacy from the patient or consumer perspective. So I urge all of you to be more mindful of these issues. And to be sure, nationally, ACLU is not the only group raising voice to these important policy. I've already quoted from some sources, but I urge all of you, if you get more involved, or probably through your work in class for those of you who are doing that, to review some of the papers and discussions and tackle these important privacy issues from the patient perspective. Now, since clearly I have more time, before we get to questions, I want to touch on the state law that was enacted in 2009 that creates the pharmacy database. It's the pharmacy monitoring database in the state of Oregon. And I'm just curious, can I have a raise of hands of anyone who's familiar with this law? Okay. You better be on. Yes, I know at least one person who should be. This is a law that was passed in the Oregon legislature in 2009, but it hasn't come into operation yet. But what it does is it allows the government to collect all prescriptions for Schedules 2, 3, and 4. Now, I'm sure as many, if not all of you know, that's most of your pain medications, as well as other medicines such as Ritalin and sleep aids. The system is available to providers and pharmacists as well as the government. The ACLU opposes this because it turns lawful Oregonians into suspect drug seekers. They anticipate that millions of prescriptions in Oregon will be added to this database every year. And many, if not most of us, will be on that database. And while we recognize the benefit to medical providers, those who have concerns about someone appearing who's a drug seeker, we believe in this case, unlike the discussion around the electronic health care records, that the risks to patients and consumers outweighs the benefits. There are significant risks to misidentification of patients. The system can only use name, date of birth, address. Some other systems across the country use social security number. The original draft of this legislation early on, and it was under the auspices of the Board of Pharmacy, basically set forth in the state law, they can collect name, date of birth, address, and any other information that the Board of Pharmacy decides by rulemaking. Translation, social security number. So even legislators who were great proponents of this drew the line there. And so they wrote into the law that could not include social security numbers. But it raises an issue, and we don't have the solution. That's why we think it's a problem. What is a unique identifier? Lots of people have the same name, similar names, even the same date of birth. And in fact, early analysis and summaries by the Department of Human Services, which now has this, talked about the fact that it's really a tool because there'll be misidentification. It's a tool for doctors. So if you look up your patient, you've got some questions because they seem to be appearing in the system a lot recently, that you have a conversation with them. It also allows pharmacists to look it up upon presentation of prescription. Pharmacists have very different relationship with patients and consumers than doctors do. And most often, if infrequently, they don't have the opportunity to dialogue and discuss. You may call in the prescription, it may get a refill, they may run your name and go, I've got questions about Andrea Meyer. Well, it looks like she's had codeine and this and that at various pharmacies. I'm not comfortable filling it. Law doesn't require the pharmacist to fill it. And if I show up there on a Friday having had a root canal, and I've had a root canal, and I've got a prescription, the pharmacist is uncomfortable because the database is showing something, I may be stuck. Where do I go? What recourse do I have? This is, for years, when I testified on this bill, and I talked about the breaches that occur across the country on health care records, they say, yeah, but it hasn't happened to one of these. So what Andrea is saying is really, that's not happened to the pharmacy databases. Well, guess what happened in Virginia a few years ago? The pharmacy database was hacked. And as best we know, someone from the outside obtained all the information. It's now a reality. And here's the concern I would have about the risks and why someone might be interested in hacking the system. If you are a drug seeker, what better information than to have my name and my address and the fact that if I were a pain patient and had a lot of medication legally, under the guidance of a doctor, in my medicine cabinet. I have to say, if I were a Virginia pain patient or anyone having a number of those medications, I would be quite concerned about my home. So we just think the government collecting this information on our personal medical and collecting it in a state-run database, which can be accessed by doctors and pharmacists, raises significant risks. I was asked to provide what a legislator called sideboards. Not really heard that term before, but I guess, and raise the concerns and what protections we could put in that legislation. And I did my best, and yet maybe not the best I could do. One of the things we put in there was the ability for a patient to get a free copy of their report. I mean, how do we audit this to ensure that the doctor or the pharmacist actually has a relationship with the patient? How do we ensure that the staff people aren't accessing it, that there actually is the relationship? Part of it is the patient. I want to be able to get a copy of my report and see if a pharmacist in Medford looked up my name. Well, I don't have a relationship with that. I want to be able to report it to the state and say, you need to look at this. Maybe it was unintentional. After all, they're running a name check with the date of birth. I think there's some automatic violations in looking at medical records of people who are not your patient by virtue of that system that are raised. I know many of you have dealt with, and I've talked to providers. I mean, there's very strict issues around looking at records of people who are not patients. And how is that handled there? Well, the commission that was formed was all sort of the stakeholders in the medical care community. And, I thought this record was to be for me to provide an audit. That's what the legislature said. And I want to make sure that that record that I get a hold of when I look at my record includes who has looked at it and when. And I was disturbed, to say the least, that one of the commission members of this group thought that the report is fabulous so that the patient can know what medications they're taking and have it listed all in one place. Completely misunderstanding the purpose and the need for a patient wanting to access those records. I understand, but I haven't heard for sure that indeed if I request a copy of my record, that means I will know who has looked at my information and when. But I keep urging the Department of Human Services and then through rulemaking to add an additional piece. So I find out that someone's looked at my record impermissibly. Now, the law allows for litigation. It allows for me to bring a private right of action to sue. That can tell you for improper use. But I have to prove as high level that there was an intentional element here. Now, I'm going to tell you, most people don't want to do that. Here's what I would want to do. I want to call the Department of Human Services and say, this pharmacist or this provider in Medford has been looking at my record. You need to look into that. Either their access needs to be removed, the system needs to be fixed, because someone who doesn't have the authority is looking at my information. What are you going to do about it? And I keep hitting a brick wall in my discussion about this and it not being addressed in rulemaking. And again, it's kind of this continued issue, as I feel, as a disconnect to understanding from a patient perspective what privacy protections we would want as consumers. So those are some of the issues that we look at and consider when we're looking at this. And I'm really happy to try to answer questions as best I can. I qualify. I am not a lawyer who has worked in healthcare law. You've probably got other experts here on that, but I'm happy from a civil liberties issue perspective to try to answer any questions about that or anything else I haven't raised. So I hope you, thank you. And we have lots of time.
I'll start, and in starting, I would like to remind everyone, especially those who don't routinely attend these conferences, if you could press the button on the microphone in front of you, because this is, with our speaker's consent, being recorded and will appear on our website, and so we want to be able to capture your questions. I want to, I think you'll find that most of the views of folks in this room are mostly sympathetic to yours. I want to ask a question about granularity, because one of the concerns I have, well, actually a few concerns. I mean, one is just sort of the practical nature of how you kind of keep track of who can and can't look at when someone needs emergency care or things like that. But even to go to your example of the podiatrist treating the ingrown toenail, that's a surgical procedure. That podiatrist may be prescribing drugs that could potentially interact with other drugs that the patient is on, and one of our goals, one of the things we think is the value of these systems, is to be able to detect those kinds of interactions. There may be some bleeding, even minor surgical procedures. Sometimes you can tell from a simple blood count whether someone is likely to have AIDS or something like that. Just some of those kinds of issues. It's really difficult, I think, sometimes to segregate what is, I don't even know the best word to describe, non-essential, even that's not a good way to describe it. But I'm just curious what your reaction is to that.
And, there may be other better examples than that one. It may be the dermatologist. I mean, I think we can imagine situations where the information is relevant and where the information isn't relevant. And, you already have that tension right now. You already have, is a patient giving me all the right information? Do they remember all their medications? Have I got all their health care records? Were they honest about everything? I think we already have that tension at play. And I don't have the right answer. But I think it's important to probably establish the levels of trust necessary so that patients are more willing than not to provide the information and have the exchange of information, rather than, how do you segregate out? But then again, how do you deal with the situation of a woman who had an abortion? Doesn't want anyone to know. I'll just pick that one because we know it's not specially protected health information under Oregon law. The way they're approaching it right now is, in terms of formulae in Oregon, is to just look at specially protected health information only, which is limited. So how do we deal with the person who had mental health treatment 20 years ago and medication, or 10 years ago, and isn't having the medication anymore? The episode has concluded. They are not comfortable having that record transmitted to institution and doctor to doctor, because it does increase the risks that if it's transferred to a number of places, unless all those places have high level of security, if there's a breach in any of those places, it magnifies the risk of the individual patient that their information will be disclosed at some point. So I don't have an answer. I think we've got the problem today. I will tell you what doctors I've gone to, and we'll get a copy of those records. If I don't tell you what doctors I've been to, or I've been treated out of state, and I come in for whatever reason, you may not have all my health care records now. So it certainly creates an ease of transmission. And, you have that luxury of like, oh, great, I get that all now, and you're in the ER room. You've still got responsibilities there that exist today when you ask for a copy of someone's records. If I go to a doctor and I have a medical health issue, and I've also had mental health treatment, so I've got a separate file with a separate provider, right now I may make that choice. Dr. Smith, yep, I've been to Dr. Jones and Dr. Meyer. But I may not tell you about Dr. Susan right now, and I can control that. You aren't going to know, right? So how do we preserve the choices that I currently can make about those sensitive things? It's hard. I'm going to go start over there, and I'll make my way around.
Thank you. With HIEs popping up across the country like mushrooms, is there a trend towards opt-in or opt-out? And should there be a trend? Should there be a standard across states?
So I'm not sure that I'm as well versed on what is really happening. I think it's a discussion in a lot of places, and there may be others. I think probably I would speculate that the trend would be to opt out rather than to have someone opting in, but I think there are some states that are looking or have done that. But it raises a whole other question. I mean, then you've got added onto this, how do states? Is it the interoperability? I mean, how do we, Vancouver and Portland, how do you do that? The protections in Oregon law versus the protections in Washington law. It is a complicated use of technology that we are creating. My feeling is that it has been less patient-centric and less honoring sort of the consumer concerns as they approach it because, I mean, rightfully so, it's the people who are the most knowledgeable and who are going to be using the systems, who are creating the systems. They're the experts. I don't deny that and wouldn't want them not in the room. But how do you really meaningfully get? Do you have a consumer representative on a commission? What does that mean? I mean, one person is supposed to carry the burden of many different perspectives based on economic status, race, religion, senses of privacy. There's some people who go, I have nothing to hide, share it all, I don't care. Except when the government gets it wrong and they might get detained. Then they might be worried about it. There's others who might go, you know, I don't want the government to know. My mother, who is 81, when we would go to the doctor as children and they'd say, you know, Social Security number, she'd go, why do you need it? Because that's, as you all know, or some of you are probably not old enough to know, that was how medical providers, that was your ID. She understood Social Security numbers for the federal government for Social Security. She grew up in that time. And I learned early on, ask questions. Why do you need to have that number? No, you can't have it. So it's a complicated area, but I think in terms of really bringing in the consumer perspective, it's not happening as well as we would like. Sort of answered part of your question. Add more. Go ahead.
I think fitting into both of these questions is the question about opting out and then still getting the quality care, which you mentioned, because I think that, as you said, most of the experts are deciding how the systems are being built, and I can tell you that that is true from both type of consumers. There are two different type of consumers, patients and healthcare providers. And at this time, I think both of these consumers are feeling kind of left out from the whole process. But the promise of Health ID is improving quality. So if we think that Health ID is going to improve the quality, then if you are opting out, you are not going to get the quality which everybody else is going to get. Mm-hmm. So I think that probably everybody needs to understand that too.
Right, and we need to look at, well, why is someone opting out? Have we not established the necessary trust and safeguards to assure them that we recognize the real risks? We've purchased the Cadillac, not the Pinto, of the kind of IT that we need, the encryption and everything, the authentication, all those things. And that, you know, we will treat this even more carefully than we've been able to treat paper records. If you do that on the front end, you may not have that many people opting out, but likewise, if someone chooses not to or isn't ready yet, you know, if it's really truly meaningful that you have the option to opt out, then they still need to provide you health care. And that's what I was talking about earlier, which is, you know, if you create the situation where it's like, yeah, you can opt out, but, well, I'm just not going to treat you, then that's a coercive opting in. And that's not meaningful consumer choice. Okay, lots of hands. Great. I'll try to keep my answers short so we...
Hi. Excellent talk. Thank you very much.
Thank you.
I am struck that there is this dynamic tension between your point of view and medical professionals as there is between defense attorneys and prosecutors, because you are seeing the cases of all the innocent people who are unjustly affected by some inappropriate release of their information. On the medical side, I also know that medical people have to deal with all kinds of people whose motives are suspect, drug seekers, people who, in extreme cases, seek to abuse themselves or abuse their children by subjecting them to unnecessary medical procedures, people who want to fraudulently bill for medical procedures not done. So from our point of view, I mean, I think as a person who has been in the medical system off and on for a while, I can easily see that there's a lot of guilty people out there who need to be caught. So how do you reconcile the need to protect the innocent with the need to make sure that people don't abuse the system?
Well, I think first those in the medical community and all of us need to know that you're never going to solve those issues. Regardless of what system you use, you will have all of those still happening, and you may not be able to catch them. So if you're building a system that you think this is going to deal with medical identity theft and drug seekers and lies, I think your premise is false. Now, is it a tool to improve some of those things? Possibly. But you already have issues of trust right now with patients not giving you the information for concerns of privacy and other things. So you already have those tensions. And, that's why we look at the electronic health care records, because there is a benefit to the patient. I can say, yeah, if I end up in the ER room, and I have, and they've got access to the system, and I've been in Oregon, and they can look at it, I will get better health care. When I had my emergency appendectomy, they had an old something of me that showed, oh yeah, this is you are having an appendectomy, or appendicitis, and you need surgery. So it's useful. But and sorry, I lost my train of thought because I went back to a few years ago. But I think, so I just want to say, so that's a benefit to me, right? Electronic healthcare records, I can, as an individual, you can sell it to me. You can actually sell it to me as a privacy person committed to issues of privacy. You can sell it to me, and I can understand that, and I will have a difficult decision. And I get why I should opt in or something. Can't sell to me the pharmacy database, because I'm sorry. I use those drugs in Schedule 2, 3, and 4. I have never had a problem working with my provider to get the medication I need. There's no benefit that comes to me by having the state database it. There's no benefit that comes to me of the risk of having my information hacked into and released, and there's certainly no benefit to me when there's a misidentification of me. And it's amazing that in the legislature, when I would talk to staff people or other folks or lobbyists, I couldn't find one who actually, when they just talked to me personally, said that they liked that system. Now, medical providers do, and I completely understand why. It's a tool so that you try to limit the drug seekers. But you know what? That is the risk of a medical practice. And I'm not sure that's going to go away by a database. You may have a false sense of security. Okay, I saw that there was someone back there, and then I'll come up here, then I'll go around there. Was there someone back there? Okay, Justin, you go ahead.
I actually have two questions.
Oh, okay.
The first question is back on a philosophical question, is whether or not patients understand the implications of not sharing their information. Do they understand that it may actually negatively impact their treatment? The other question is on the pharmacy databases. Will the ACLU be challenging that law in court?
So let's go to the second one. Will the ACLU be challenging it? Currently, I don't see a legal basis for which to challenge it. It was a state law passed. There's issues around, do they need to seek specific authorization from HIPAA, from the federal government? There's a debate around that. There is a discussion that they may set the system up so that doctors would get an automatic notice if the patient exceeds a certain amount. I've suggested that's outside the scope of the law and what it authorizes. So, we will see. These databases, and I'll add this quick thing and then move on to your other question. What I find amazing, and I hope you all consider, is these databases exist in like 30, 40 other states. No one has evaluated. The purpose of them is to reduce drug seekers. Oregon's looking at it more as a healthcare tool. Some use it as a law enforcement tool. There's now attention in Oregon from law enforcement and the others who want to do that. But no one has evaluated whether these are effective, whether these do what they hope to do across the country. We're spending a lot of money in Oregon to create this database with risk. And I am really dismayed that before the Oregon legislature made that decision, they didn't say, prove to us this addresses the concerns in a meaningful and appropriate way, and they haven't. Do patients understand the implications of not sharing? Well, I kind of turn the question back to you. Isn't that already an issue today? Do patients understand the information, not sharing mental health information or other information that I talked about with the study showing that they're already not? And how do you deal with that now? Is it, it's work. And I know the whole issue is around cost and everything and time with patients, the ability to establish those relationships and that trust. It needs to happen today. It's going to need to happen even more. Go ahead. Did you push your button?
Oh, yeah.
Sorry. Good. Thank you.
Yeah, so actually it's, I guess my question is related to this last point that you made. Now, let's think about two extremes where I go to a healthcare provider, I have a conversation, some tests are done, then everything gets sort of like self-destructs, everything is taken from the record. That's like the most secure thing. Right, and then the other end, everything immediately is made publicly available on my Facebook page, something like that. So,
okay.
So along this curve is...
One you have a choice on. Okay.
So along this curve are sort of points with different trade-offs for essentially privacy security versus added sort of benefit in terms of medical care. Mm-hmm. And so the fact that now with consumer choice, you're suddenly given all these knobs, right? And with granularity, actually, you're given many more knobs because now you have to essentially, there are different trade-offs for different types of information, and you have to somehow decide for yourself where to place this knob in terms of like in this trade-off curve. This record made available to this kind of provider, but not to that kind of provider. Usually, in social settings, I think, when people are presented with this responsibility, it's, I don't know if anybody studied this, but, it's actually, I think it's very hard to ensure that people are making reasonable or beneficial choices because it's really hard for them to understand the impact of their choices. Now, you say that this actually happens right now also, but the fact is now we're thinking about this scaling up scenario where hopefully when sort of all the information converges, there will be added benefits. So we're not talking about, now is not really comparable, I think, because, yes, now you can hide your information that you had, I don't know, you had some surgery some years ago in some other country. You may not say that, but that's the whole point. The whole point is that making that decision, essentially, of talking about that or not, will become part of that knob adjustment process, which it is not today. So sometimes, offering all these choices is not necessarily providing benefit. I don't know. What do you think about this?
I think there are a lot of challenges, and I think, as I mentioned earlier, having those privacy policies where they sign, they may not understand that that's actually less privacy. I'm responsible for the state law related to genetic research possibilities with collecting biological material and the ability to opt out, even if it's anonymous research. Because with genetic information, there is no such thing as truly anonymous. The challenging societal question is who decides? Who knows better? How do we get to a place where the medical world knows a lot and needs a lot? They know a lot in terms of how to best do their practices. They need a lot of information to best do their practices. But our society has to also have some control in individuals. And you raise the interesting and the challenges, and I don't think there's an answer on either side. I think it's a long process, and it's a hard one. Did you have your hand up?
Yeah, I wanted to follow up on the pharmacy database issue.
My favorite topic.
The way it was, when you described it, you were saying the alerts would come at the point when the prescriptions were being filled, or the pharmacist would be the one to intervene. When it has been shown to be very effective within the VA system, when the information is given at the point to the actual physician writing the prescription, and they do need the information. Right now, I think they can only get it from the VA system, right. Other locations, but it seems to be more of an issue of having well-defined roles about who should see it, and maybe not the pharmacist, but not that the data itself is at fault, or we shouldn't have the databases.
Well, let's address a few things. First of all, in terms of the alerts, the sending out, that's not allowed in the law, and hopefully they won't go there. It is accessed by a pharmacist or provider who's submitted who's signed up and been authenticated, and then they can access it on someone they are or about to prescribe or give these medications to. And you're presuming, so yes, I've always had a huge objection to the pharmacist having it. If the role is to provide the opportunity for the doctor, if they believe that their patient is a drug seeker and this is giving them a red light to that, to have that discussion. If the doctor prescribes it, then why should the pharmacist, and the doctor hasn't chosen to check the system, and why should the pharmacist have a second check and may misread it? Because the doctor can say, I see you've never lived in, you can determine if that's really the right person. But you're also presuming that the data is accurate and that you're actually getting my information when you look me up. And that's not necessarily true. And fundamentally, well, it's a great idea and I understand the need, we are asking our government to collect that information and to keep it. And we just have a fundamental problem with the government requiring my personal medical information to be turned over to the government for collection and retention for their access in a limited situations as well as possible doctors or possible pharmacists. To us, that's where we draw the line. I don't want the government to have my personal medical information, and I don't want to be forced because I have a drug to be entered into that database.
But you have no issue with within system, say Kaiser, to be able to do this?
Well, those exist, and and hopefully you've got the safeguards and security systems, and that's the private sector, so I have less sort of Fourth Amendment government involvement. I hope there are the protections and the remedies available for me if you breach that system. But that's part of the system. I'm in the legacy system. I know it's all there. Let me go back over here. You had your hand up.
Going back to the opt-out issue, this technology is really, it's going to take decades to really fully realize the benefits of the EHR. And people, you might be able to get away with people opting out now without it making a big impact in the system, but sooner or later, there are going to be real costs associated with opting out. And these costs are going to be in higher insurance claims in case of malpractice issues or quality of care issues, and reduced ability to discover patterns, health patterns, all these things. So who is going to bear the costs of opting out?
Well, I mean, I think you raise a good point if we move to giving an option for opting out. One possible remedy to that risk is that you've created a system that has vibrant, vigorous safeguards and remedies available to people when it is misused or abused or not secured. When you create a system where if I go and I'm given the option to opt out, but I understand how secure the system is and that, in fact, I have better protections now than it was a paper record, and if there is a breach, I know about it, and if you're negligently handling it, I have a remedy available, okay, I'm opting in. I get it. Or if you're going to move to even a state where someone can't opt out, then you better have the best protections in place, because what your result will be is if I can't trust that the information will not be released inappropriately, and I don't have a choice to opt out, I will not tell you what's going on with me in my health care. I will not seek health care services. I will be too concerned that it's going to be shared. And I think, so you've got a cost factor, but you've got a lot of different ways. But I think one of the ways to start addressing it is the vigorous security systems and remedies available to build the best system so that people, if they aren't given the option to opt out, or they're not persuaded to opt out.
I guess from a practical perspective, I'm thinking of if patients choose to opt out, and it costs a healthcare organization significantly more money to manage that patient's care, can that cost be passed along to the patient?
And I'm sorry, I'm just looking because I'm checking on what time someone's coming to, okay. I have to deal with another Joint Terrorism Task Force and a reporter at our office, but I've got a few more minutes so I can stay.
Opting out has a cost.
Everything has a cost, and I don't have the answers. I don't have all the answers. I can raise the issues. And yes, opting out, everything related to this has a cost. This is not necessarily, I don't know. I haven't studied. Has anyone evaluated whether creating these systems will actually create more cost? I mean, it's intended to improve health care and to save costs. I don't know that we know as we venture into this thing that will take a decade or so, whether we know that that will be the result. We hope so, but I don't know if it will be. I know a hand over here, and so go ahead.
How much do you think the fear for the privacy is based on the fact that people don't think they can get justice served if they do have abusers on the system? You know, trying to go up against somebody who's released information, large company, an individual is not going to have a lot of success in suing them. So how much of the fear of the privacy is based on people who don't think they can get justice when they've been have their information abused?
You know, I have no study. I think that's a piece of it. I think people have all kinds of different fears, and I know with my understanding with HIPAA is, at least right now, if there's a violation, I don't have a private right of action. So, you know, the federal government can pursue if an entity is violating it, but I don't get any relief. So providing that as a piece, we've always urged to give that safety valve and protection that the individual will feel like. But again, like I talked about in the pharmacy database, I mean, most people aren't going to want to sue. You have to find a lawyer. Are there attorney fees or even available? Is it nominal damages? Versus I want you to stop doing that and have a better system in place. So, yes, you want a quick follow-up? Or, okay.
Why don't you take one more question because we're about out of
time. Okay, or maybe two because I pointed to them. But I'll be, okay. Okay.
If we're to believe the public reports that prescription drug abuse has exceeded the overdose rate of heroin and illegal drugs, would this be an invitation to doing something about it? Or we should just let Darwin's law take place and eliminate the species that abuses?
That's a good question. And that presumes that all the drug abuse going on is by prescriptions improperly received rather than someone going and shopping in their parents' medicine cabinet and sharing the drugs. So I think a lot of the abuse, and I haven't looked at the data, but I think it shows a significant amount of it is not based on fraudulently obtained prescriptions, but misuse, abuse, and sharing of lawfully obtained. And you will not be able to remedy that with a pharmacy database. You are really only remedying the drug seeker who is able to get 3, 5, 6 prescriptions. And that doesn't get to, I don't think youth are, the troubling numbers related to youth and the prescription drugs that they are using will not be resolved. That really is their parents' medicine cabinets. It's going to parties and sharing it. A lot of it, not all of it. So we mislead ourselves if we think that database is going to resolve those issues.
Good.
Great. Well, thank you.
Thank you.
I really appreciate it.
I was just going to say, while you were talking, an email came over my phone that 3 people were fired from University of Arizona Medical Center today for disclosing records of people who were operated on over the weekend after the shooting.
And the problem with that, it's good they were fired. The problem is we hear about it, and that reduces our level of trust because it's happened. No.